None of this you learn in medical school. So everything we're talking about is not learned in medical school.
Dr. Peter Attia is back. He is a Stanford, Johns Hopkins, NIH-trained physician who focuses the applied science of longevity with everything he does.
If you go and see somebody and they have their own pharmacy, that's a red flag.
Whether it's his podcast, The Drive, and or his book, Outlive, which has become a Bible for me. And he joins me today to talk about all things hormone replacement therapy for women.
Because I got to make you 14 again, and I'm going to give you like enough estrogen to kill a small pony.
You will get no greater expert on this subject matter to guide you in conversations with your doctor and empower you to take control of your health.
Once a woman hits about 20 or 25, I mean...
Time to go. Time to start.
Keeping it real with Jillian Michaels.
Peter, I think this is the first time I've addressed you as Peter for your
so
request in our third podcast together. Thank you for coming back.
Thank you for having me.
You're an absolute mensch. You must want to die. Every time I get a hold of you, I don't let you go. I'm going to do my best to keep this one as concise as possible. But selfishly, I have wanted to pick your brain forever about this. And when I first learned about you, you would think it was like the project that you did with Thor, your book, which obviously I'm obsessed with and bought. Which camera am I in here? Outlive. That said, I believe I saw you first on a podcast saying that the Women's Health Initiative study about hormone replacement therapy for women was arguably the most botched study in medical history. And for years, I had thought of HRT as just the most deadly and dangerous thing because of that. And I was like, wait, who the is this guy? And I was riveted. And subsequently, I began to obviously learn more about you and become a devotee and worship at the altar. That said, women ask me now these questions about HRT. And while I have some understanding, thanks to you, you are the doctor, the guy, and I wanted to do a show that is essentially a Bible for women to educate and empower themselves on what there is to know about this. So my first question just generally is, what is HRT? Is it an anti-aging protocol or is it a therapeutic treatment for menopause? And to be dead honest with you, I actually don't know.
You know, it could be thought of as a bit of a semantic question, right? So it is clearly a treatment for women going through a transitionary period of their life when their hormones go away.
Okay.
When their natural production of two hormones, but really a third if we include testosterone, but estrogen and progesterone, when the natural decline of those hormones occurs, how can we replace them with hormones given exogenously, which is just a fancy word for given outside the body, from outside the body. Okay. So that's really what it is. Now, what does it mean to be anti-aging? I'm not really sure what that language means, but yeah, you could probably make a case by the end of this podcast that we will have argued that things that occur when a woman ages that are not desirable are slowed. There's no doubt that that's true. So if that makes it an anti-aging protocol, so be it. The way I think about HRT is, what does it do to improve things that you feel that are getting bad? So I always break things down into things you feel that are bad and things that you don't feel that are bad. And how does it impact both of those? That might be the easiest way to think about them. So not surprisingly, maybe we should start with the things that you feel. Okay. So it always seems a bit weird when I talk about this because I'm not a woman and I'm not going to go through menopause. And so in that sense, it feels like, well, yeah. So, but yes, what I'm saying, I guess just to preface this, everything I'm talking about is sort of based on an obsession with this literature over the past decade and treating women. Right. So you know, just hopefully folks don't come at this thing. What the hell does he know? He's never been through menopause. That's true.
He was like, doctor.
Right.
I think we're good. You're good here.
Well, but
your medical degree I think covers you.
But none of this you learn in medical school. So everything we're talking about is not learned in medical school. Because remember, when I went through medical school more than 25 years ago, that was, first of all, this just wasn't something that was taught. But secondly, as soon as I finished medical school, the Women's Health Initiative, which we will probably talk about,
Oh,
was
yeah.
published, and it basically, I think what I probably said was something to the effect of, it's not just that the Women's Health Initiative was a lousy study, it was interpreted in an abhorrent way, and the media was incredibly culpable in failing to hold this horrible reporting of the study to any standard. And what it did was created a lost generation of women, right? These women who were born in, basically the late 40s and early 50s and into the late 50s, frankly, who were just completely deprived of HRT. So call it kind of late 40s to mid 60s. That demographic of women have largely been screwed horribly by this because they were sort of thrust into, well, you're just going to go through menopause and there's nothing we can do about it. And that includes the symptoms that we'll talk about,
Can I
but also these
argue
things we
though?
can't feel about.
Okay, hold on. And you're right. I apologize to interrupt you. I must admit a bias, and I please club me over the head. I just go for it. I need to, give me the perspective of my position will be, well, we've been doing this for thousands of years. This is ridiculous, Peter. Why do
Right,
I need
right.
drugs?
No, great question. So we have to understand that things that we've been doing for 1,000 years, and it's really 250,000 years. That's how long our species has been around. That whole period of time, from 250,000 years ago until 100 years ago, or 150 years ago, when modern medicine showed up, the whole purpose of evolution was optimizing for your reproduction. It didn't care if you lived past 40,
Yeah,
right? It wasn't optimizing for that.
I see.
Once you produced your offspring and once you transmitted your genetic material, evolution, Mother Nature, Darwin had no use for you. So while it's true that women, if they managed to live long enough, 50,000 years ago would have suffered miserably. I would argue they were suffering pretty miserably for a whole bunch of other reasons, like the tigers, the lions, the infections, all of the other stuff that is just generally pretty miserable. Menopause was probably the least of their worries.
Fair.
You know.
The marauding, hordes and yes, okay.
Yeah.
The raping, pillaging, and plunging
Yeah,
of
those
neighboring tribes.
things must have been a little worse than the menopause. But it's these goddamn night sweats that just can't handle this. Yeah, not the problem. So, but we're lucky now, right? So in the latter
Thank you for
part
the
of
perspective.
yes,
Okay.
in the latter
Got
part
it.
of the 19th century and the early part of the 20th century, we emerged from the swamp of hell that was our existence for 250,000 years, and largely on the basis of sanitation, antimicrobial agents, the development of the light microscope, and processes for allowing women to give birth without killing themselves and their babies. We can't ever forget how devastating that used to be. We all of a sudden got to the point where we can live to 80 years old now. And now we have the luxury of worrying about heart disease, cancer, atherosclerosis, Alzheimer's disease, osteopenia, osteoporosis. We have the luxury of asking the question, should a woman in her 50s and 60s still enjoy sex? Should she be deprived? Should she not have to have night sweats? Should she not have to have brain fog? So again, this is just the luxury we find ourselves in because we solved all of those other problems.
That makes perfect sense. Okay, so back to the symptoms that you recognize and then the things wrong you don't recognize. The symptoms you recognize we've covered, right? Am I missing anything?
Yeah, the big ones are typically the first things that occur are what are called vasomotor symptoms. These are night sweats and hot flashes.
Okay.
And those are resulting from the reduction in estrogen. So maybe we just take a step back and talk about how the whole hormone situation works in women.
Got it.
So,
Yes, please.
So women, we talked about this on a previous podcast, which was that testosterone is still more abundant in women than estrogen, but estrogen is kind of the defining hormone.
Are there 3 forms of estrogen?
Yes. There's estrone,
Okay.
estradiol, and estriol.
What's the difference and does it even matter?
It matters a little bit,
Okay,
but
so
maybe
not
for the
really.
purpose of
Keep it
this
rolling.
discussion, I would say
Keep it rolling.
yeah, estradiol is the dominant one.
Gotcha.
Maybe when we talk about sort of edge cases of hormone replacement therapy, we can talk about the use of estriol.
Got it.
But I think for the purpose of this discussion, women should understand that estradiol is the dominant form of estrogen. And um, just like we talked about with men, when the gonadotropin releasing hormone from the hypothalamus tells the pituitary to make follicle stimulating hormone and luteinizing hormone, the ovaries make more estrogen. And this is a cycle that occurs. Now, what's really interesting.
And progesterone?
Yeah, progesterone. So I think the easiest way to kind of picture this, and I did a video on this once, and maybe we can find it and you can link to it somewhere when this podcast comes out. Because
I can insert it.
yeah, it's like a 10-minute video where I actually walk through the female cycle
Oh, we'll
in
link to it.
hormones. So I show, because for women, it's much more complicated than men.
Oh, wow.
Because in women, you have a rise of follicle stimulating hormone, a fall of follicle stimulating
Throughout the course of the
hormone.
month.
Yeah,
or
you
cycle.
have a luteinizing hormone spike. You have a spike of estrogen that then comes down, followed by a second spike that then comes down, and then progesterone is sort of laying dormant until the very end of the cycle when it rises to prepare for implantation. And unless you're pregnant, it then comes crashing down. And it's the crashing down of the progesterone that leads to the kind of PMS symptoms in women that are susceptible.
Which is also kind of related to postpartum as well.
Yes.
Sorry.
And it's it leads to the shedding of the uterus, the lining of the endometrium that leads to the period. So when those estrogen levels are going down, the first symptoms that are going to typically show up for women are these night sweats and hot flashes. Again, those are called vasomotor symptoms. They will, in most cases, go away over time, but the variability in how women experience those is remarkable. But I would say most women, long before they become amenorrheic, which is the technical term for when your period stops, they know it's coming because, one, their period starts to get irregular. But two, they start to develop these symptoms, right? They're like, oh my God, like I woke up in a total, my sheets were soaked. Or I just get these really hot flashes, like if anyone's ever taken niacin or something and knows what that feels like.
Oh my God, is that what it feels like? Because yes, I've taken
that's what I'm
niacin.
told it feels like. Again, I haven't experienced it. Yeah.
Of course not. Sorry.
Yeah.
Oh, that sounds, now that genuinely sounds awful if that's in fact
and
what
then
it
I
feels
think
like.
the other really big symptomatic component are the sexual side effects.
Okay.
So some of that can be loss of desire, but a lot of that ultimately becomes what's called vaginal atrophy. So that means reduced lubrication, and actually atrophy is a word for shrinkage, right? So a shrinkage of, the sexual organs, basically. What is the net result of that? It generally makes sex painful and undesirable. And so there are solutions to that do not involve HRT. They're not as effective, but you can use topical estrogen in that case to overcome both of those situations. Again, it's nowhere near as effective as systemic estrogen, which we'll talk about, but which is a part of HRT.
Okay.
So the third symptom that I think is not uncommon with menopause is kind of like the emotional and cognitive symptoms. And again, it's not the case that every woman will experience every one of these. You can't try to ram this sort of playbook down everyone's throat and say like this is going to happen. But women should be prepared to at least experience brain fog and potentially just depressive mood, right? So irritability, all of these sorts of things, because it's just hard to overstate how important these hormones are. And even in ways we don't fully understand. I mean, we know we have receptors for them in our brain as well. Right. So it's not just that estrogen and progesterone receptors are found in the reproductive organs. They're also found in the brain. And so therefore, it shouldn't be that surprising that when you are losing those hormones, you're going to not just experience reproductive symptoms, you're going to experience cognitive and emotional.
Dr. Lisa Moscone is a neuroscientist, isn't she? She's like, and then she wrote the XX brain for menopause and dementia. And I was like, well, that's scary as hell.
Yeah.
But, okay.
So now we start to get into, so if all of those things become the symptoms, now we get into, okay, these aren't symptoms, but these are problems. So first and foremost is bone health. This just doesn't get enough attention. So the probability of a person falling when they're 65 and up is about 25%. That once you reach the age of 65, you've got about a 25% chance in your lifetime of having a fall. And somewhere between 10 to 15% of those falls could be fatal if you break your hip or femur.
Why is that fatal? I don't mean to take you down a long path. Is it because you can't get out of bed, or like what is and it's like all broke the hip, she's gone.
Yeah.
What is that? Is there
There's the short-term reasons because the fatality stats are usually within the first year. And
Oh.
so it's not just like you
It's
die
the
and
impact over time of
yeah.
how it limits your mobility and got it. Never mind. I'm with you. Sorry.
Yeah, it's like
It's a
if you took a
big picture.
20-year-old and put them in bed for a month, they'd recover. When you take a 70-year-old and put them in bed for a month, it's very difficult to recover.
That's enough said.
Yeah.
Okay.
So women are disproportionately at risk for falls. They're about 2x the risk because they have less muscle mass. They tend to be on average less active, and they have weaker bones. So the reason for this is estrogen is the most important hormone in bone health. So the way bones work um, is they have little, for lack of a better word, strain gauges in them. So strain gauge is like, it's not an actual strain gauge, that's a term we use in engineering, but a strain gauge is something that detects deformation.
Okay.
So when you pick up something really heavy, your femur,
Okay.
your bones experience deformation. They're being shrunk slightly. The body, through estrogen, and estrogen is the chemical signal that transmits that information, which is there is deformation, to the cells that remodel and build bone. So, both for men and for women, estrogen is hands down the most important hormone in bone health. And this is why women experience a disproportionate reduction in bone strength because they have a sudden loss of estrogen. Whereas in men, the loss of estrogen is a little more gradual as they age because it falls in line with testosterone levels. In women, it's uncoupled. It falls like that.
Okay.
So that's sort of, I would say, reason number one from a medical disease standpoint beyond a symptom standpoint. Then you have the relationship on type 2 diabetes and heart disease and Alzheimer's disease. You referred to Lisa a
Heard of
moment
that
ago.
one? Yeah,
Yeah.
the Alzheimer's disease. And I have the G1 ApoE4. I'm very mindful of this one, but diabetes. Why?
Well,
I don't understand.
probably because
What's that
estrogen and
insulin? What did
progesterone
I
play a
don't get
role
it?
in insulin
They
sensitivity.
do.
Yeah.
Oh my God, I didn't. Okay.
And that might explain why women are more likely to gain weight post menopause, but they're
Right.
becoming more insulin resistant.
Okay. Again, I want to beat it.
Yeah.
So I don't want belly fat, although I must admit, just a little, that I've noticed as I've gotten a bit older, but just a little, because I've never stored body fat there in my entire life. Unfortunately, it's like lower body and not in the great places like my ass where I would love it to be, but no, quads, so upsetting. That said, okay, I work out now. I got muscle. I'm doing my VO2 max training like
Yeah, yeah,
Peter
yeah.
told me to do. I'm doing my strength training like Peter told me to do, which I do. Um, like a
And all of
prescription
that's
from
going to help.
you,
All of that is going to
it will
help.
help.
Yes,
Okay.
absolutely. Yeah, this is not like a one-way ticket to hell. But
It
you have
does
to
seem like a
remember,
slow descent into decline. It does seem like you're
well,
fucked.
sure, but that's aging, right? Like the
Okay.
truth of it is that's going to happen.
And you've always
But we
been
just have to
fair and
say,
realistic
like,
about that.
but when women experience this sudden drop in hormones, it is going to accelerate a trend towards type 2 diabetes. Does that mean
It's
that
gonna
when a woman
happen.
goes through menopause, she gets type 2 diabetes? Of course not. There are plenty of women who go through menopause who don't get hormones, who don't get diabetes. So we're
It's
just
a
talking
compounding
about
factor.
gravitational pull.
Understood.
Yeah.
Okay. Okay.
Um,
Okay.
cardiovascular disease. There have been mixed results on these studies, but what I think we can conclude based on the best available evidence today is that estrogen is protective from future cardiovascular events, doesn't really reverse any cardiovascular disease that is already present, and this is where it gets super nuanced and painful. There seems to be a significant difference between if you initiate estrogen during the perimenopausal period, which is when we should be doing it, versus if we start estrogen in a woman a decade or more after menopause. So this is a big part of the injustice of this entire discussion we're having. There's going to be a woman who's listening to us,
She's
who's 70 years old,
yeah.
whose bones are brittle, who's at risk for heart disease and maybe dementia, who was part of this lost generation of women who was deprived of HRT 20 years ago when she should have got it in 2004. And she's going to say, well, sign me up for that. And there is no doctor, I mean, there are some, but there are very few doctors that would be willing to give her estrogen because her quote unquote window is closed.
Windows closed meaning the hope of benefits are gone.
The
The
risk?
bones are already brittle.
No, it's not even so much that. It's that people, because we have such a paucity of data for what happens when you initiate HRT that far out, that there is enough concern on the part of doctors to say, I'm worried that if I start HRT on you now, there's a risk I'm going to actually make some things worse in you. I'm going to increase your risk of dementia. So,
Okay, so are we leading ourselves into this botched women's health initiative study then? Because I feel like you had said the women in the study were already past the window.
that's right.
Okay, so I want to back up for 1 second and establish what I had thought until you. Oh my God, blood clots. Right, we're having blood clots.
And there's some truth to that. Oral estradiol does slightly increase the risk of blood clots. Now, I don't know the last time I gave a woman oral estradiol because it's a lousy way to deliver that hormone. It should be given topically. It should be given in a patch. You can give it in a pellet. So there are lots of ways that you can give a woman estrogen that don't involve a pill and that don't have any of those increases in risk. But it is true that estradiol taken as a pill will slightly, it's not a huge increase, but it's a slight increase.
Okay, but it's avoidable, so just don't. Right, we'll talk a bit more about that when we talk about the form as well of like what type and patches, creams, noses, vaginal, all the things. Okay, cancer. Oh, everyone's getting
Talking
cancer.
about that, yeah.
Right, so we're getting blood clots, we're getting cancer. Can it cause heart disease? There were all these findings, so much so that I was under the impression that they stopped the Women's Health Initiative because it was so bad, so deadly and dangerous.
Absolutely rabid.
Until you.
Yeah.
So what's wrong about this? How is this so botched?
I've spent so much time trying to deconstruct and understand how this went so bad. I've even had one of the 3 principal investigators who led the study on my podcast.
Oh God, that couldn't have gone well.
Well, of the 3 main investigators, she's the one that's done the closest to a mea culpa and acknowledged that mistakes were made.
Wow.
The other 2 have not come close. So it was actually not it wasn't like a brawl, and there were a few moments of we'll agree to disagree. But I do give her credit for being the one to say, yeah, we kind of botched this, and we should really revisit the idea of HRT, at least under certain circumstances.
How was it botched? So you got the element of the ladies
So there's
being
2
past
things
the
that
window.
there's 2 things that botch an experiment, right? There's what is the design of the experiment?
Okay.
And
this
then
is the method section of a study
yeah,
or
this
something?
is like how do you design
did you do it?
Yeah,
Got
how did you do it? Right? Okay. And then there's the how did you interpret it?
Oh.
And it's very important. Science is, I have a hypothesis. It's a guess. Right? Feynman famously said a hypothesis is just a fancy word for a guess. I have a guess. The scientific method, not natural to our species. We didn't do it for 250,000 years. We didn't have this tool, but we now have this tool, which is when you have a guess, you can design an experiment to test if that guess will be right or wrong. If the experiment produces an outcome that confirms the guess, we now say that hypothesis was very likely to be correct. There's never anything that's 100% in science. Very important to understand that. In mathematics, we do proofs. In science, there's no such thing as proof. There's probability. It's just high probability, low probability. Some things are in the middle. Okay, so which of those 2? I think the Women's Health Initiative had significant errors in both. Now, the errors in methodology are forgivable, and this is an area where I've become more tolerant in my old age.
Today, I want to introduce you to an amazing tool that's helped me in my work with literally tens of thousands of people in helping them boost their energy, helping them feel better in their body, helping them lose weight, helping them maintain a healthy body weight. It's Lumen. Lumen is the world's first handheld metabolic coach. It's a device that measures your metabolism through your breath, and on the screen of the device and on their app, it lets you know if you're burning fat or carbs and gives you tailored guidance. to improve your nutrition, your workouts, your sleep, and even your stress management. Your metabolism is your body's energy. It's how your body turns the food you eat into fuel that keeps you going. And because your metabolism is at the center of everything your body does, optimal metabolic health translates to a bunch of benefits, including easier weight management, improved energy levels, better fitness results, better sleep. Did I say that? Did I say that already? You know why? Because it matters that much. Lumen gives you recommendations to improve every aspect of your metabolic health, and it can also track your cycle, as well as the onset of menopause, and adjust your recommendations to make sure that your metabolism is healthy through all hormonal shifts. So guys, it doesn't get better than this. Just go to lumen.me/Jillian to get 20% off your Lumen. That's lumen.me/Jillian for 20% off your purchase. Thank you, Lumen, for sponsoring this episode. There's something for everyone, including your loved ones. I mean, it is the holidays. And in my opinion, everybody needs one of Quince's iconic Mongolian cashmere sweaters, Heaven, which start at only $50. Or if you really want to up the luxe factor, check out their Italian leather handbags, washable silk skirts, European linen sheets. Whatever you're looking for, all Quince items are priced 50 to 80% less than similar brands. Quince only works with factories that use safe, ethical, and responsible manufacturing practices, so treat yourself and your loved ones this winter without the luxury price tag. Go to quince.com/Jillian for 365-day returns, plus free shipping on your order. That's QUINCE.com/Jillian to get free shipping and 365-day returns. Quince.com/Jillian.
So the experiment took women and put them into 3 groups. Any good experiment has to have a placebo,
Yes, right.
right? These are women who don't get
Saline.
anything.
They're taking saline
They're taking
or
a
something,
pill.
but they think
They're
that's
taking
blinded.
a pill that they think is the hormone, but it's not.
Got it.
Okay. The second group were women who had undergone hysterectomies at some point in their life. Now, if you have undergone a hysterectomy, you do not need progesterone as part of your HRT regimen. Now, technically, that's true from a cancer perspective, but it's actually not true. In general, whether or not you have a uterus in place, progesterone can still be beneficial. But if you go back to the very beginning of time when people started playing with hormones in the 50s, they were just giving women estrogen because it was making them feel a hell of a lot better. But then they noticed, oh, these women are getting endometrial cancer at a higher rate. And then they said, oh, actually, the reason that's happening is we don't have a hormone to oppose the estrogen, and this endometrial lining is getting very, very, very thick. So then they reversed course, started giving women estrogen and progesterone, and lo and behold, that problem went away. So today, the traditional thinking is if a woman has a uterus, she must have progesterone with the estrogen. We're going to talk about how what is done today, which is that doesn't have to be oral progesterone anymore. It can be a progesterone-coated IUD if the woman can't tolerate progesterone. So we'll come back to that.
Be able to tolerate progesterone, nausea or something?
No, usually it's moodiness, irritability.
Oh,
Yeah.
God. Okay.
What I typically hear my female patients say when they have too much progesterone in them is, I would like to kill my husband, is the typical line. So that's, to me, that's a good symptom. Like that's the symptom, aha, we have too much progesterone in you. So fast forward to the 1990s now, the mainstay of therapy is for women who have a uterus is something called conjugated equine estrogen.
Premarin, pregnant mare urine.
Yes. And MPA, which is a synthetic progestin. Okay.
These aren't bioidentical, right? Because
Correct.
horses have like numerous forms of estrogen
Very
and we
good.
have 3.
That's right.
Okay.
So you have this conjugated equine estrogen, which we just were using because it was so readily available. It's
Got
not
it.
like we believed women should be getting horse estrogen, but it was just like, this is the abundant way to get it. So if a woman circa 1990 was in menopause, she was given, and she had a uterus, she was given conjugated equine estrogen and MPA, synthetic estrogen, or horse estrogen, synthetic progestin. And if she didn't have a uterus, if she had undergone a hysterectomy at some point for any other reason, she was just given the conjugated equine estrogen, CEE. So the Women's Health Initiative study was, we're going to have 3 groups. We're going to have the placebo group, If you have a uterus, you're going to be CEE. You're going to be randomized to either placebo or CEE plus MPA. And then
Progesterone and estrogen,
and
but these conjugated synthetic forms.
technically there were 4 groups because you had 2 placebos.
Got
You
it.
had a placebo, you basically divide them uterus, no uterus, and then placebo, CEE plus MPA, placebo, CEE only. Okay, so that makes sense?
Yep.
I'm kind of confused that a bit. So now the question became, what happened in the study? So
I thought it was a hell in a handbasket. They all
so
dropping dead like flies, and we stopped the study.
the first thing women have to realize when we're talking about hormones today is I've never prescribed CEE or MPA in my life, and I don't know anybody who does.
So that's changed. Now it's bioidentical, meaning it matches the human forms of estrogen.
That's right. Now when we give women estrogen, we give them the actual hormone that their body made. And when we give them progesterone, we give them the actual hormone their body made.
Right, not
the
some
only
replica.
exception to that is oral contraceptives, where we still use synthetic hormones.
Okay.
So we can talk about that if anybody cares, but to just put a pin in it, the reason synthetic hormones are used for oral contraceptives is they have a much higher binding capacity for the receptors. And when you're giving a woman an oral contraceptive, your only goal in life is to make her stop ovulating.
Well, that actually answers one of the questions, which was, what's the difference?
Yeah.
So that's
Totally
actually
different.
Kind of a big difference.
Right. So putting that aside, when we treat women for menopause and perimenopause, I'm sure there are some doctors out there who are still using the old hormones, but I don't know any of them. Like
Okay.
the doctors that I would know,
Would never dare.
you just wouldn't do it. It's just such. It doesn't even make sense. So that's one of the huge limitations of the study. And I've asked this question point blank of the investigators: why did you design a study with such lousy hormones? And in their defense, they said because at the time most doctors were still using them.
Yeah.
And you know what? I'm going to give them a pass on that.
Okay.
I think that's fair.
Fair.
The next aspect of the experiment that really was lousy, I have also become a little bit more understanding of, but much less so. And that is that the women in the study, by definition, couldn't be symptomatic. Their argument, if we did this in young women who are perimenopausal and menopausal, who are just entering, they're going to be all symptomatic. Well, no woman who is symptomatic would agree to be in a study where she runs the risk of getting the placebo, because then she can't get hormone replacement therapy. She's going to be miserable. They're going to drop out of the study. We're going to have no study. So, because at the time, HRT was viewed as a given. Of course you give women hormones.
Right.
All the epidemiology said HRT is wonderful. Women do so much better on HRT. So when the NIH came along to fund the Women's Health Initiative, what their initial goal is we just really want to make sure this isn't causing more heart disease and breast cancer. Even though all the epidemiology says it's great, it's wonderful, it's amazing.
Got it.
And they were like, we're never going to be able to enroll in this study. Like this was $1 billion study, by the way. I mean, it's an enormous study. And they said the only way we're going to do this is if we get a bunch of women who are so far out of menopause and that they won't know the difference if they're getting the placebo or the treatment.
Okay.
It's further confounded by the fact that many of those women did receive HRT when they were younger.
Got it.
So it's an absolutely abhorrent, filthy cohort of data that sucks.
Wow, what a shit show.
But then it gets worse.
Okay.
Because all of that is just prelude to how bad this is going to get.
We're not done talking about how bad?
No, God, no. So now we get to the main course.
Missed that part the first time I talked about it. Okay.
The study design was merely the amuse-bouche. You haven't had the entree. The entree is how this study was interpreted. The lies that people had to tell themselves to make sense of the data. So
I usually see this the other way, Peter, and forgive my bias, but usually it's like, oh, the drug companies are funding it. So of course the drug companies want you on their drugs. You know, it's usually the other way, not the, don't take drugs. I've never seen a don't take drugs study.
That's a fair point. Well, Nancy Reagan had a couple of those, but
fair.
So what happens? So there are many things they're looking at: colon cancer, heart disease, diabetes, osteoporosis, osteopenia, et cetera. But the thing that got all the attention was breast cancer. So let's talk about that. there's a thing called relative risk and there's a thing called absolute risk. So let's pretend your risk of getting food poisoning if you go to that particular restaurant over there, the risk that it happens is 1%. So if you would go there 100 times, you would expect to get food poisoning one of those times.
Mhm.
Okay. I come along and I say, I now have, let me make the math easier, 10 times. Okay, so it's 10%. This is obviously crazy. You have a 10% chance of getting food poisoning if you go there.
Okay.
So if you go there 100 times, you're going to get food poisoning once. But now I say, Jillian, I have a magic drug that I'm going to give you that is going to reduce the risk of you getting food poisoning. And let's find out how much it happens. So I get a whole bunch of people in a study where the base rate of getting the food poisoning is 10 out of 100, 10%. But after the study is done, you guys only get food poisoning 5 out of 100 times. That's pretty good, right? Okay, so what's the relative reduction in the risk of food poisoning? It's 50%. Would you agree?
Yeah.
You went from 10 cases in 100 to 5 cases in
Yeah.
100. What's the absolute reduction in risk? It went from 1% to 0.5%, or one. In this case, because I boosted the signal, it went from 10% to 5%. So it's a 5% reduction in absolute risk. So you go back to the way I phrased it at the
I
outset.
gotcha.
When I said you had a 1% risk
Mhm.
and I took you down to a 0.5% risk, that would still be a 50%
because it's half of
relative
1%.
risk reduction, but it would be a 0.5%
Yep, I got it.
absolute risk reduction.
Yep.
And then there's a number that we like to think about called the NNT, the number needed to treat, which means how many people do you need to treat to appreciate that risk benefit, and it would be 200, right? Because the
Yep.
NNT is the reciprocal of the absolute risk reduction. So just keep that in the back of your mind as we talk about this.
Basically saying they blew these numbers way out of proportion.
So what were the numbers? So what happened in these two groups? So there's two parallel experiments. There's the conjugated equine estrogen
Yep.
with placebo for the women with no uterus, and then there's the estrogen and the MPA with the versus placebo for women with a uterus.
Right.
Okay. In the group that got the conjugated equine estrogen alone versus placebo, the risk of breast cancer went down by about 1 case per 1,000.
Okay.
And the relative reduction was about 20%.
Okay.
So there's a reduction in the risk of breast cancer in that group, both in absolute terms, although it's trivial, and relative terms. It didn't
go up.
It didn't go up. It didn't reach statistical significance at the conclusion of the study. It did 15 years later because they followed these women overall.
Right.
So there is a small but real reduction in the risk of breast cancer in women who were getting conjugated equine estrogen only. In the women who were getting both conjugated equine estrogen plus MPA, the risk of breast cancer went up just slightly. It went up from 4 cases per 1,000 to 5 cases per 1,000, which, if you can do the math, what's 5 divided by 4 minus 1 times 100?
Oh, shit.
25%.
I'm like, don't do this to me right now.
No. It was a 24% increase in the relative risk of breast cancer.
Seems massive.
Seems
but it's nothing.
unbearable.
Yeah.
Until you realize it went up by 1 case in 1,000, 0.1%.
Right.
Furthermore, that was an increase in the risk of getting breast cancer, but when you looked at mortality from breast cancer, there was no difference. And interestingly, that result has also persisted 20 years later. 20 years later, it's gone down a little bit. It went from 24% to 20% increase in relative risk, and the absolute risk remains at 0.1%. Now, if I were transported back in time looking at those data, the first thing I would say is estrogen alone has about a 20% reduction in risk. Estrogen plus MPA has about a 20% increase in risk. Neither of these have a clinically significant change in breast cancer. Would your conclusion at that moment, well, let me ask you, what would you conclude explained the difference? Let me reframe the experiment. What if this group was cookies give you less breast cancer,
Right.
cookies and
Milk.
carrot
Right.
give you more breast cancer? What do you think?
Well, I would just remove the carrot.
Right. So interestingly, I think any person with an IQ above 82 would look at the results of that experiment and at least hypothesize
That it was the
that
carrots that caused the
MPA
problem.
might have been the problem. Right? I mean,
Of course,
right?
yeah.
Like I've only been thinking about this for 15 years, but it would appear to me
Sorry,
that
it's not funny. I don't mean
that the CAA only group or the CE only group
the
has a
estrogen only group.
has a reduction in risk. The estrogen
And
plus MPA
progesterone
group goes up a little bit.
Remove the
So
progesterone.
either, there's only two explanations here, right? Either there's something about the women who have a uterus that is making them more likely to get breast cancer, or what I would call the Occam's razor explanation is it's actually the MPA. It's actually the synthetic progestin that's driving up the risk. But instead, two headlines emerged. The first was breast cancer risk increase with HRT is 25%.
Yeah.
Now, that's technically almost true. There was a 24% increase in the relative risk of breast cancer, but it's not entirely true because it was only in the group getting this other treatment. And the second headline that emerges is estrogen causes breast cancer, despite the fact that there is nothing anywhere in the Women's Health Initiative at all that says that estrogen had anything to do with this. And those results persisted 10 years later and 20 years later at the reevaluation of those patients.
Wow.
So even if
In fact, it was quite the opposite. It actually reduced risk slightly.
That's right. So even if we think it makes sense to give women conjugated equine estrogen and MPA today, and nobody really does, what I like to tell women is, look, at a minimum, your risk is probably going up by 0.1%. And let's evaluate that increase in risk against all of the benefits that come with it.
Right. And in addition, can I ask you, like, family history? I don't have a family history of breast cancer.
Mm-hmm.
If I did, would it matter?
It might, right?
A little.
So we still live in an estrogen-phobic world. There's no doubt about it. We still live in an estrogen-phobic world. So we have to sort of be able to...
The estrogen positive cancer conversation, right? Then it's like, well, early onset cancer diagnosis is up massively. And X% of it is digestive tract stuff, and then X% of it is hormone positive stuff. Estrogen, breast cancer being top of your list. So then you're like, uh-oh, estrogen positive.
Yeah, but remember when we did the program and we talked about TRT for men, we talked about the role of testosterone. See, there's a real analog between how testosterone works in prostate cancer and how estrogen works in breast cancer.
Yes.
It's quite a different thing to say, if you have a raging prostate cancer, pouring testosterone on it will make it worse. That might be true. Just as if a woman has breast cancer and it is a raging and it is estrogen sensitive, if you give her estrogen, you might make it worse. That's an entirely different proposition from saying, if you take testosterone, you will get prostate cancer, which has been demonstrably demonstrated to not happen. And I believe that it is pretty clear that giving estrogen does not cause breast cancer. Now, if you have a woman who is high risk for breast cancer, you would take a lot of steps to make sure that you are evaluating her and screening her.
Got it.
And but the truth of it is, if you look at the data very carefully, it is not clear that estrogen would have any role in the initiation of breast cancer. And by the way, like you can even just look at this in a crude way, which is, if testosterone was driving prostate cancer, young men would be getting it.
Of course.
But it's old men. It's men with low testosterone that are getting it.
And I've subsequently heard that...
And it's the same is true with breast cancer.
That's what I was just going to say that. I remember hearing that, thinking, like, I don't get it, but I'll circle back later, talk to somebody about it at a later date.
On average, not always, on average, women are getting breast cancer when they have less estrogen than when they have high estrogen. So you had this perfect storm of lousy study design, very poorly interpreted study, and then media that really loved the idea
The
that this was a contrarian finding here. All
Wow.
that time you thought HRT was good for you.
So can I conclude after this whole talk that really there's no negative side effects for perimenopausal women with HRT outside of potentially a family history of breast cancer where I should be monitored by my doctor to just screen me regularly in the event something develops. So not because of this,
Yeah,
but
I
in the
look,
event, and that this doesn't accelerate or act as an accelerant on the breast
I
cancer.
have yet to see a valid piece of data that suggests to me that HRT will increase the risk that a woman dies of breast cancer.
Can I jump to the next conclusion? Would all women benefit from HRT?
You know, that's an interesting question. My knee jerk response to a question like that is no, because I think it's very difficult to say all
Okay.
fill in the blank anytime in medicine.
Mhm.
Again, my intuition is that the answer to that question is probably no. But what I think is really valuable is the idea that every woman should be offered the discussion, and that's again. So we're sitting here more than 20 years after this study was published. And it's hard to know because I live in a bubble, right? Like I live in a bubble where
Really do. As a
and so
doctor that knows everything you know, and I say this only
so I don't
because
know how bad it is
it's
in
pretty bad.
in the real world. I don't know what
Uh,
fraction of women are not even given this opportunity to
I
have the
would say
discussion.
most,
Yeah,
and
that's just if that's right, that is a
you
tragedy
gotta
of
seek
epic
it out.
proportions.
And here's what I mean. So as a 50-year-old woman with many friends in this age range, I generally have to be the one when they're telling me their whole world is falling apart, which happens all the time, to then say, hey, watch what Dr. Attia says about this and then go talk to your doctor. I think I've done that 10 times in the last 3 months. And it's even the friend of the friend, so it's like my friend, then their friend, and she's like, oh, talk to Jill. Then Jill says the same thing. And then they go talk to their doctor. And I'll be honest, I haven't even had this conversation with my doctor yet. And I what is it, an internist?
Look,
A
I
gynecologist?
think there are great internists that can do this. I think there are great GYNs that can do this. Um, uh, Historically, this would fall in the purview of your primary care physician or your
Okay.
gynecologist. Um, and
They
look, we
don't, Peter, and
no,
they
yeah,
don't even know.
I
Like, I've also
but just
heard.
as we would have a urologist or a really good primary care physician should be able to manage TRT in men. Um,
So
I
talk
know
to
for a
your
fact.
internist or your
Yeah,
OB/GYN or
and I know
both.
for a fact that there are great examples of both of those types of doctors that do this. There are also hormone clinics. That's become quite in vogue. And I just think,
Nicole?
well, I think it's all going to come down to like who the people are. I've seen some that I think are doing good work, and I've seen some that are absolutely ridiculous. They're giving women Herculean doses of estrogen. They have this thesis that says, I got to make you 14 again, and I'm going to give you like enough estrogen to kill a small pony. And I think that they're potentially doing harm in that regard. So, they're loading them up on, massive doses of testosterone and growth hormone and doing all sorts of crazy things. So, just because
Oh,
someone's got a clinic, I think you got to kind of hear out their philosophy a little bit
of
and
course.
ask, like, how are you managing this? What is your philosophy around, the use of these hormones, and what hormones do you use? Do you have here? I'll give you a big red flag. If you go and see somebody and they have their own pharmacy, that's a red flag.
Is a red flag.
Yeah.
Why is it compound? Why?
Because I think it's a conflict of interest. I don't think a doctor should be prescribing a medication to a patient when they make money on the medication.
Oh, but you're okay with compounded hormones.
Um, I we don't
Oh,
tend to use them because I always prefer to have an FDA product. The quality assurance is so much higher.
but it's still bioidentical.
Yes, we use bioidentical estradiol, of which there are many FDA-approved products, we use bioidentical progesterone that is an FDA-approved product.
Got it.
Now, compounding runs rampant. Some compounding pharmacies are really good.
Some have certain standards, right? And then
There's
others
2
don't.
standards of them, that's right.
Yes, okay, which is a separate issue, but
Yep.
nevertheless,
I did
there's
a whole
no,
podcast on this topic, by the way.
which we'll link to, guys, which absolutely people should check out, especially because of what's going on with Ozempic.
Yes.
So I strongly recommend on any and all subject matters to check that out because there is a big difference as far as I can tell, and you need to know what you're dealing
Yeah,
with.
it's compounding pharmacies are the Wild West, which is to say there's some good and there's many bad.
Got it.
But when in doubt, always opt for an FDA approved product, even
Okay.
if you have to pay a little bit more for it.
Got it. Okay. So now then, explain to me if you can, um, how long? So I remember talking to Dr. William Lee about something, and his mom had gotten cancer, right? And it's because according to him, I think one of the elements was they left her on HRT forever. Nobody ever took her off. Why would you ever come off? How do you know when to come off?
So there's no good evidence to answer this question.
Shit.
And so what most doctors are doing is having, I think if you're a good doctor, what you're doing when a woman has been on HRT for a decade, which seems to be, so if you look at the people who were staunch opposers of HRT that are kind of coming around to it now, they're doing so with many fences still, right? They're saying, okay, maybe the Women's Health Initiative was wrong. Maybe HRT is not, the worst thing in the world.
Right.
But you must start it immediately. I agree with that, by the way.
That's going to be my next question.
In fact, you should start it during perimenopause. You don't want to wait until you're fully in menopause, but we'll come back to that.
Yeah, we got to come back
And
to
then
that.
they would
Sorry, my
say,
bad.
and you really
there.
shouldn't do it for more than 7 to 10 years. Now, if you
Okay.
push and ask why, they'll say, because of the risk of breast cancer. To which I then say, what risk of breast cancer? They'll say, the Women's Health Initiative. And I say,
shit.
right, but the Women's Health
We're back
Initiative
to-
didn't really show an increase in breast cancer.
Right.
It showed that CEE plus MPA increased the risk of breast cancer by 0.1%, but didn't increase fatality of breast cancer. Is that the risk you're talking about? They'll say yes. And I'll say, so that's the reason we're telling women to stop at 10 years?
What is the reason?
That's the reason.
Oh God. So then.
So the
So
mantra.
What do we do now if I've been on
the
this?
mantra of HRT today. So we went from this is amazing.
Everyone's on it, right?
Then we went to you'd be better off rubbing cyanide on your inner lip. And now we are minimum effective dose for the shortest period of time.
Yes,
and don't tell anyone and hold your breath while you're taking it.
Yeah. That's not where we should be.
I don't believe so.
So
But that's where we are. Which is an improvement over don't ever touch this stuff.
What if I'm at a window of 7 years? Do I keep it rolling or do I is there a what do I
Again, this is not a particularly compelling answer, but I do think I hate saying this because it sounds like such a stupid cop-out. Every case has to be evaluated individually.
Fair.
My view is that if a woman really understands what benefits she's getting from it and understands what the risks are potentially, most women tend to say, I would like to stay on this. Thank you very much.
So the risks don't accrue over time.
No, and again, I think there's some very confusing data on brain health, where the Women's Health Initiative showed that there was an increase in the risk of Alzheimer's disease in these women who started it very late. Now, today, we don't really know what to make of those data, although there are data that show the opposite, that if you actually start HRT early, you improve brain health.
It's all that Dr. Lisa Mosconi stuff.
That's right. So there's also some data that show women with an ApoE4 gene disproportionately might benefit from estrogen. Because remember, we have to acknowledge that Alzheimer's disease is a very asymmetric disease. It afflicts women twice the rate of men.
And this is arguably the reason, right? The estrogen.
I think this is a big part of it because that delta of 2x cannot be explained by the delta in life expectancy.
Right.
It can't. In other words, mathematically, it's not the case that because women live longer, that's why they have twice the rate of Alzheimer's disease.
We get it. Yeah, we get it at younger ages anyway. It doesn't matter. It's not like we're getting it at 100. You
So
get it at 70.
the most obvious thing is that something about the sudden loss of hormones, and maybe estrogen more than progesterone, but possibly both, would play a role in that. So I can just tell you that for most of our patients who are at that point in time where
you're not ripping them off of it
we're
based
definitely
on
not ripping,
based on an arbitrary number of 7 to 10 years.
We're definitely not ripping them off it. And when we have that discussion and try to present the data, because the data are the data. Like you know, I want people to be very familiar with all this stuff. I mean, I used to keep copies of these studies. I used to keep a copy of the Women's Health Initiative and all of its published subsequent studies on my desk, just because this is back, you know, when my practice was in person and before it became a virtual practice. But so that if a person is sitting there, I'm going to be able to show, you know, this is the data. Like you can look at the tables and figures too. You be the judge.
Yes, understood.
So yeah, so I think that I think it's overly cautious to just say we should arbitrarily stop HRT 10 years out or 7 years out or whatever it is. Because again, when you push on that argument, they just say, no, but look at the WHI, these women that were older, they had bad outcomes. And it's like, yeah, they were on a different hormone. B, they started very late. And B, these were very unhealthy women. That's yet another element of that study
Right.
that is.
What you're talking about that is they already had all these health issues.
That's right. Yeah.
Okay. So now I've got a series of questions that I'm going to link together because I'm hoping it will flow. When do I start? You said perimenopause. I kind of don't know what that means. In other words, I should be in perimenopause. I'm 50, but I don't have symptoms. So is that me?
Yeah, you might not be, right? So perimenopause is a vague idea that is like there's a set of symptoms which I'll never be able to rattle off because some of them are obvious and some of them are not. And
I just be like, you're 50, you're in perimenopause?
No.
Like Shirley Jill, you are?
No, definitely not.
Shit. Okay, good.
Yeah, so
what
it's
about a
like,
blood test?
yeah,
I've heard you talk about a blood test.
Yeah, well,
So,
we'll talk about the blood
you
test.
talk
but-
about also like you have to go on a certain day of the month or something?
Yep. But before we do that, what are those symptoms, right? So,
Okay.
so are periods getting more spaced out? Are they getting heavier? Are you are you becoming more moody or irritable? Are you getting any of the vasomotor symptoms?
None.
So no. So I'm saying like
Yeah.
you go
Whereas
through that
when- yeah.
list, and that's how you sort of do the math. Now, from
Okay.
a biomarker standpoint, the first thing that we start to see is a rise of FSH on about day 5. So that's our window. That's the most consistently reproducible time to check estradiol, FSH, and LH levels. So if we define day 1 as the day the period starts.
Oh, so
That's
so
day
like
1.
right when it ends, kind of a thing is when you want to check it?
Yeah, depending on it. If it's but even if you just spotted for 2 days, we would still check you on day 4 or 5.
Okay.
If you had a heavy period that went 6 days, we would still check you on day 4 or 5.
So not common knowledge, Peter.
Yeah, and then we would look at what is your FSH, and what you're going to see is if you're a young woman, if you're a woman who's got a regular cycle, your FSH on that day is going to be like 2 or 3 or 4 or 5. As you get more and more towards menopause, that FSH starts to really ratchet up, and there is no defined cutoff at which point I would say you're perimenopausal or menopausal. But I will tell you that once a woman hits about 20 or 25. I mean,
Time to go. Time to start.
it's
Get
to
going.
me I would
That's the
add that
moment.
to the list of we're
So that's
starting.
a pretty good indicator. So now I want that blood test. No one's offered it to me, and I have great doctors. Maybe because I'm not bitching. So
Yeah, I mean, in their defense,
I mean, they're
if you're
really good
if
doctors.
you're totally asymptomatic and you're not hitting any of the 9 symptoms that we would typically see in perimenopause, I think it's reasonable that they're not losing sleep over what your FSH is on day 5.
Okay.
Yeah.
Now, so that's a great benchmark. It's quantifiable.
Yep.
Fantastic. Testosterone. Okay. So all I try to do is block this, and the reason is because I've had breakouts my whole life. I had PCOS as a kid, and I say as a kid because no symptoms really outside of. Gynecologist recently ordered a pelvic ultrasound, and the lining was a little thicker than she wanted. It was a whole freaking cancer scare, and they did a biopsy, and it was nothing. Nevertheless, this is like a thing of mine. It's linked to PCOS and all this shit. So all I do, and I told you I turned into like a little bulldog, which I freaking hate. And I'm the person that arguably doesn't exist, where I do 3 squats and I get thighs this big that everyone's like, no, it's not a thing. It kind of does happen to me. So
You really picked the wrong thing. You should have been a bodybuilder.
I know, but I hate it. And then I hate. It's so weird because I'm such a boy, but I kind of don't want to look like one. So like I feel like I have the brain of a man, but I don't really personally want to look like a man. Not that there's anything wrong with that. So, and hair. I want to keep my hair. I don't want pimples all over my face. And I tried Accutane twice in my life. My body would break through it. Nevertheless, here we are. And my dermatologist and my gynecologist put me on spironolactone, and it works.
Yep.
And it's like, what medications you on? And I love saying none, except, and I'm like, but not because I'm unhealthy, just because like, I could break out. So I block the shit. I'm like, I do not want this DHT, don't want it. And then I'm like, was this
but
bad?
look, you're
Do
not.
we need to replace testosterone?
No, we don't. Yeah, we don't need to. And again,
When do you
like,
know if you do?
well, again, like if your libido is tanking and you're having a hard time putting on muscle mass, and your testosterone is demonstrably and measurably low,
So when do you test for that? Can you do it the same day as FSH?
it's less relevant. You can test it any day. But yes, if you're going to go through the trouble of testing a woman, I'm going to look at her FSH, her LH, her estradiol, and her testosterone and free testosterone on that same blood draw.
And what should it be for a woman number-wise? What's our window?
Yeah, so for women, we would typically see a total testosterone, and it depends on, this is another important point.
Okay.
I am really adamant that these hormones, both for men and women, are only checked using something called LCMS, liquid chromatography, and mass spectroscopy. And so if you go to LabCorp, you can have your doctor specify LCMS testing for estradiol and for testosterone. And that's really important because the enzyme-based assay for those hormones is really quite inaccurate, and it's remarkably inaccurate in people who are taking supplements and things like that. So
God,
we
that's
see,
me.
I mean,
Take a million
yeah.
supplements.
So unless you're getting an LCMS, you can throw the numbers out. It just means nothing. So if we're going to go through the trouble of doing all of that, and you're getting a proper LCMS, I would say a normal testosterone for a woman could be anywhere from 50 to 100 nanograms per deciliter.
Okay. Oh, God,
Remember,
so much lower than men. It's supposed to be
right, men would be 500 to 1,000 would
Okay.
be normal.
Yeah.
And then a free testosterone would be probably 1% of that.
Okay.
And the reason is women have much more sex hormone binding globulin.
Okay.
So they're going to have a lower free testosterone, the lower percentage as free. So their free might be, like 1 to 2 or something like that.
Okay. Is there a way to get the androgenic effects that you mentioned of like muscle maintenance and bone density?
Anabolic.
I'm sorry. Anabolic without the androgenic of like face.
No. And so
Shit.
with women, the two most common symptoms of testosterone replacement are acne and hair growth.
Now,
With women, though, there's another trick, which is
oh,
you
there
don't
is?
have to
What's
give
my
them.
trick?
Well, it's not. It's
What
just
is it?
you can give them DHT instead of. Sorry, I'm saying DHT. You can give them DHEA. DHEA is a precursor to testosterone. It's another.
What if I want to go to the vitamin store and I can buy? You can't.
You can. In the U.S., DHEA is legal over the counter.
Should you not be doing that then?
No, I'm just saying that there's an interesting difference. So it's men think DHEA is a great way to boost testosterone, but it's not in men because DHEA only boosts the testosterone that's produced by your adrenal glands. So in the case of, and by the way, it does the same in men and women, but the difference is if a guy's testosterone is 300 and he takes DHEA, it goes from 300 to 330. Doesn't make a difference. But if a woman's testosterone is 30 and she takes DHEA and she gets 30 more, she goes to 60, she's normal. So DHEA is actually a pretty cool trick for women to replace testosterone without taking testosterone. But again, I just don't recommend you do this without having a person who knows what the heck they're doing.
People are messing around with this stuff all the time, and it's like even when people ask me like, "What are you taking?" I'm like, "Well, I take fish oil. Talk to your doctor. All this stuff interacts with different drugs. You don't know what your levels are in your blood. Like, always talk to your doctor and have them look at your
and
fish
hopefully
oils and shit,
hopefully you've got a doc that
knows
cares
what he's
enough about
doing.
this stuff.
Yeah, which is
You have to be a little curious because you're not learning this stuff in the normal channels. Like you sort of have to,
I hate
do
to
a
tell
little
you.
after school learning.
Okay, so how do I know if I need progesterone if I have a uterus?
Yep. So if you have a uterus, you have to have some form of progesterone if you're taking estrogen.
Got it. Because
or you
otherwise
will
the lining
experience the
builds
lining
up.
thickness.
Check.
So our strong preference is that women take what's called systemic progesterone, a pill. They take oral progesterone. And the reason for that is progesterone does a lot of good that goes beyond just opposing estrogen at the endometrial lining. So for most women, it improves the quality of their sleep. That's probably the single most important thing that they experience with progesterone. It also improves mood if you get the dose right. If you get the dose wrong, it doesn't.
Right, that's when you want to kill your husband.
That's right. For most women, it increases hair thickness.
Oh my heaven.
Yeah. Um, and then obviously you get the protection against the endometrium. It also plays an important role in bone health during perimenopause.
So now I understand this whole component, and we all know when to get tested, what to look for, quantifiable numbers, that it should be at least these
So
two together.
Yeah, and when you're giving estrogen, you're treating this is much more art than science, to be clear, right? So let's
Because
just
I was going
assume,
to say, what's the right dose?
right, exactly.
That's the art.
So don't know, right? We can give you ranges. Progesterone is typically between 50 and 200 milligrams orally before bed every night. So how do you know where on that spectrum to be is not because you're measuring progesterone levels in the blood. That's not particularly helpful. You can measure them in the urine, but I would argue it's not really necessary. My view is only change one hormone at a time and treat to symptoms within a known range of the hormone. So you need at least 100 milligrams of progesterone to give you the endometrial protection.
Got it.
So then the question is, where do you need to be? 100, 125, 150, 175, 200? That's going to be while holding everything else constant. We tweak there until we find the right dose.
Okay.
So that's progesterone. We're not doing anything off blood markers. With estradiol, let's just assume we decide we're going to put a patch on you or something like
That's
that.
gonna be my next question. You've got like vaginal nose stuff, patches, pills.
Yeah, so again, it all depends on what you're trying to accomplish, but
Oh,
my
shit,
preference
okay.
is a patch.
Really?
Yeah.
Okay.
Um,
What if
and
I'm just trying to accomplish all this awesome stuff? Like my hair and my mood and my body fat and all the things. Like there's not just, isn't everybody trying to accomplish the same stuff?
yeah, I mean, I think so. But again,
Oh, I get like vaginal lubrication,
well, but
you're
yeah,
saying.
if you give vaginal estrogen, you're not getting it throughout the body. You're
Right.
you're just doing that. The only reason you would use vaginal estrogen is probably in a woman who doesn't want to take systemic hormones, but wants to do everything to kind of mitigate the sexual side effects.
But we already established that there's really no significant risk.
True, but there are
So
still obviously many women and their doctors who are still really afraid, and this is kind of like they're dipping their toe in the
this
water.
thank got it. You like the patch, you said. So it
We
would
we
be
like the patch in women. It's easy to titrate, right? So it's a beautiful FDA approved product that gives a consistent level of absorption, and you basically titrate it by trimming the size. I mean, first of all, it
I was
comes in
thinking
different doses.
how?
Well,
You got the patch.
it comes in different doses, and then
I
you would say you
see.
go half patch, quarter patch, etc.
I got it.
And you change the patch every 3 days.
Okay.
And the biomarker we look at there. So first of all, symptoms matter the most, but we get guidance from your FSH and to a lesser extent the actual estradiol level, but mostly the FSH.
Symptoms matter as in the alleviation of symptoms?
Yes.
Not like, oh God, you've developed a horn on your head.
No, you can give a woman too much estrogen. So the most common two things that you see with excessive estrogen are mood irregularities.
He's laughing at me.
But again, that
Yeah.
could be the progesterone, which is why I don't want to be ingesting these two hormones at the same time. Because you can, if a woman is having irritability or depression, how do I know if it's that she's got too much or too little progesterone, too much or too little estrogen? So just tweak one hormone at a time. And then the second thing is breast tenderness. That's pretty unique to estrogen and not testosterone, and not progesterone.
Part of the reason I'm grimacing when you're talking is simply because all of the nuance, I hate to say this, but I just don't think the majority of doctors know about or understand. I don't think they're even testing women on this fifth day like you talk about. I don't think they're even considering the testosterone component.
Yeah.
So
Look, there's got to be doctors that are watching this. There's going to be women that are watching this that are going to send it to their doctors. And
Okay.
some of those doctors are going to be like, that guy's an idiot. I don't
Really?
have time for this. Sure. And some of them are going to be like, you know what? I'd like to learn more about this. Maybe I should pay attention to this. So, it's not a great answer in the sense that it doesn't solve the problem tomorrow, but Rome wasn't built in a day. And we do have to rebuild a new medical system.
So essentially, I guess the question becomes, and I've started to learn that through talking to all of you guys, your care comes down to a partnership with your doctor. So you come in and you can ask all these questions, and you have a relationship with your doctor, a doctor you trust, a doctor that listens to you, a doctor that takes the time, and a doctor that doesn't just write this off like the guy in Miami that was like, what test do you want? You even talking about? Okay, so what day do you want your blood work? Genius. And I was like, seriously? Are you fucking kidding me?
I mean, look, that you just have to get a new doctor. Like that's not,
Okay.
that's, I
So
don't,
we gotta-
you're not, I'm not going to
Yeah.
spend time interacting with that person trying to convince them. They've already shown their hand, and there's a level of arrogance there, and there's a level of intellectual laziness that's going to preclude having any kind of meaningful
Period.
relationship. So let them go off and do their thing. Wish them well.
Yep.
And you just got to find somebody else. Now the real challenge here is, just as much as we have people on that side of the ledger, people that I just call, firmly entrenched in the medicine 2.0 system, unfortunately, you got a lot of insane quackery on the other side, where people that just want to give every woman every hormone, and they fashion themselves as longevity gurus.
Yes.
And there's a real problem there as well.
Yeah.
And so what happens is, part of this guy's reaction is to these buffoons, and these buffoons are in part a response to this guy. And so the challenge is, nobody really likes to be in the middle because it's a lonely place, and you have to take a long time to explain what's going on, and you have to spend a lot of time learning. So I do
It's like
think
politics.
Yes, I think that's actually a fantastic analogy.
Check out all the links we sent you guys in the comments here. Check them all out as discussed. Listen to The Drive. Peter's podcast is an invaluable resource. The book has a ton of this stuff in there. Get the book, which mine's signed because I had the book, but oh my God, I got a really nice long letter. Jillian, I'm gonna read it. I haven't read it yet. Jillian, I hope this book plays a small role in your quest to help people live longer and better lives. And here's to your very best, Centurion Decathlon. I love him madly. Thank you. And you're, and like, by the way, every woman in our office has a crush on you. Your poor wife. Add one. But like, I'm safe. I think I'm relatively safe. Just let her know.
Yeah.
But so I would probably turn the tables for you.
Very well, thank you.
Thank you so much for watching. If you enjoyed the podcast, please like, comment, subscribe, and share. And make sure to let me know what guests you want to see on in the future.